Good afternoon, everyone. Thank you. Thank you, Dr. Beck and Ian Andreas, and both your excellent lecture makes my talk much easier. So my slide has not an answer, some questions, and then pretty much Dr. Beck and Ian Andreas, pretty much they explain all the details. So I will more focus on the untreated person. So how was the cancer session this morning? I pretty much, I see all the bases familiar. Okay. My talk is about the regrowth, or how can manage the tumor nodular volume consistently low and well maintained. So when a patient visits my clinic and they ask, "Oh, Dr. Park, how much volume you can control or I can get after your procedure?" And especially with one session, I like to say, overall, in general, I like to say 2/3 or 60 or 70% of volume I can control, depending on the location of the nodule or initial volume. Wait a second. Then what do you mean? So that means depending on the location and depending on the initial size of volume, our single treatment session will bring all different results. And more than that, today I'd like to discuss about what you can, or there's something we cannot control. It's already nodule has a certain characteristics in the nature, and then it's out of control. We already start the treatment, we're both hands are tied up. So I like to just one by one. I like to have time to think over, what are our limitations, how we can improve in the future to have a more complete ablation. Dr. Beck's talk was more of the moving from incomplete to more complete ablation. One day, 10 years ago, when I witnessed, observed Dr. Beck's, the procedures, it's really eye-opening, amazing moment, and it was too good to be true, hard to believe, and then that's why I started my enthusiasm, and then I came here so far. So this is the report, very well-known report from Korea. They collected the multi-centers, and then they analyzed the data and how much were good after at least 3 years or more than open follow. I think pretty much this is true because this data is not from only single center. It's really from centers well controlled by the expert. And then as you see here, they used 111 patients, and then they follow over 4 years. And then the recurrence rate, they say 5.6 recurrence rate. Dr. Andreas, it's like 11% or less than 5 or 6%. That's good, quite similar. But if you see, dissect more of the practice, that is a single session only in less than half. More than half the patient in 7 to 8 hours, we did multiple sessions. I don't know, multiple sessions is 2 sessions or 3 sessions. I think pretty much in 2 sessions, right? Patient doesn't like more than 2 sessions. Then also, if you see that complete, disappearance only 18%. That means 1 out of 5 we could achieve complete disappearance. But there's no more. There's a little more details about how the size, what's the index volume. So we need more data to understand this paper. So regrowth is usually we call marginal growth. For the thyroid RFA, we treat more centrally, but Dr. Beck greatly presented about arterial first and then central and marginal vein with the anterolateral dissection. I think it's a more advanced, great technique. So regrowth originally, definition-wise, is tumor growth from the margin, untreated portion, because we treat mainly central portion of the benign tumor very easily technically. Then papers varies, like 5 to 6, 11, and then 25%. Just let's say it will be 10 to 25%. Even accept that, that means we are going to follow the patient over a long period of time. Let's say over 5 years, we'll have this kind of tumor regrowth. So this is not the tumor volume. This is the surface area. Then when let's say tumor is a sphere, then we're going to go to the corner to corner, and we're going to control completely emulate the surface of the sphere. That's really that's really not a small area, and then it's really hard, especially when it's a malignant tumor. Our goal is curative, and we should beyond go to the surface, the margin or border of the tumor. That means we are in a very challenging situation. So I divided it into two groups. One is intrinsic factors. Intrinsic factors means even I treat the similar looking nodules, but I'll have the different result because the tumor nodule has some intrinsic factor. The extrinsic factors is like that. Even the same nodule, if I treat it and Dr. Beck treat it or Dr. DeAndres treat it, we'll have a different result. I don't know who is the winner. So I like to start with the intrinsic factors, and then I like to see how we can improve our techniques. On how we can select. Usually only one, and possibly not allowed to us to have more than one evaluation tool. So I like to focus on more of the intrinsic factor. This is a graph, my calculation I made. When tumor, usually measure the tumor with the three axes, X, Y, Z, or A, B, C, depending on the shape. So when tumor, the diameter is, it's assuming that it is a sphere, it's completely round one, and the 1 cm volume, 2 cm volume, 3 centimeter, 4 centimeter, 5 centimeter volume. As you see, volume increase exponentially. So when tumor nodule is less than 1 centimeter diameter, yes, definition of the microcarcinoma, we can approach to curative. We can complete ablation, and then we can. So now advanced group approaching to more T1B between 10 and 20 millimeter. So yeah, pretty much we can have a high amount of ablation volume, but more than that, it is hard to achieve a complete ablation. And then what you can do? Thank you. Yes, Dr. DeAndrea already mentioned. Yes, when I read this article, it's really it makes sense to me. We start with the small index volume. It's easy to control it. The more the volume increases, in diameter and volume-wise, as you see, after long-term follow, we will have less, the volume control. It is true. Then, practical question like that. If you have a patient in your clinic, so then you're dealing with a certain size of nodule, diameter, volume, and then I ask myself, also I should talk to the patient. How many sessions, I can achieve, how much percentage of volume, Because the patient sometimes should pay the money out of pocket, So then they want to know what will happen, if you're going to start treatment, how many sessions, and then what kind of volume reduction, how much volume reduction I can get. Sometimes I send the patient back to the surgery. Because if I say, oh, you need more than 2 or 3 treatments, patient was so disappointed. Their expectation was with a single treatment. They want to have, just much of the volume reduction, and that's it. But if I said no, then okay, now I cannot afford it, and then they want to go back to the surgeon. So this is a slide that I made and then suggested 2 years ago during the international interventional meeting. I realized that usually when I talk with a patient in my clinic, my magic number is 2. Okay, I treat you once, and then later on, if you give me opportunity, I once more And after that, there's no improvement of symptoms, you do not meet your expectation, I'm out. So then, my comfortability was volume was 40 to 60. The reason why is our milestones, according to Dr. Beck's papers, is 6 months we should achieve 50% of bowel reduction, and then another 6 months after we'll have additional 20-30%. Overall, like a 60, 30, 2/3. Then we start with the 40, and then I can reduce the volume at least 20 and 10. If I do more, I like to make a really nodule less than 5 or 10. The same, 60, and if I reduce the volume 30 or 20, and then second time I start the 20, the milliliters volume, I can reduce down to 5 or 6. So for me, more than 40 to 60, I like to recommend, okay, surgery might be better, even technically feasible. I can do 3 or 4 or 5 or 6 times or more. Otherwise, also, there's a multiple non-avoider. In that case, the volume is more than 40 to 60. Now there's embolization, topic emerged, and then it could be an option, as you see here. This is the first report from Turkey, and then he treated the patient, and 56 patient, with the embolization single session, he could achieve 2/3, like a 60-90% volume reduction. This might be, it is true, then it's worth trying, especially substernal goiter or multinodular goiter with a large volume. It's hard to manage with RFA. The second factor that we should consider is the shape of nodule. Usually, thyroid nodule, when it is small, it's a sphere. But when it grows, it has more shape of the like a oblong or ellipsoid feature. This is a paper, just a submission from Dr. Jung from Korea. The nodule is when it's really oblong. This is a longitudinal scan, and then with a single axis, it's hard to have acute, the angulation to treat the upper pole and lower portion of the nodules. And then she supposed, we can divide the nodule into 1 or 2 or 3 multiple nodule concept, and then we can treat the one nodule and then pull the electrode out and complete the bleeding control, and then we can access the remaining portion to have more complete tumor evidence. It totally makes sense. Another one is your strategy should be based on the solid component. Everybody knows that it's hard to control the solid component with the ethanol ablation because we cannot control the diffusion of ethanol in the solid component. So all the solid component later on should be re-evaluated and treated with a thermal ablation, or you can treat it simultaneously when the solid volume is pretty large. This data from Dr. Beck group shows that when the solid component is more than 20%, the patient satisfaction rate or bowel reduction is pretty much not significant. That means solid predominant, in addition to solid predominant nodule, there's a more solid component. RFA should be the first approach. All right, so this is what is said. And then anatomical location wise, the tumor or nodule can be studied in the center of the thyroid. That is easy, but sometimes it tends, expanding, beyond the margin of the thyroid capsule. And then our strategy usually ablate the central portion, and then either upper portion, and then substernal or peripheral portion will be, the central portion will be shrunken, and then untreated portion will be located in a more easy location. That is our strategy. So I have just a personal question to each of you, and then which nodule looks like the easiest one, and which one seems to be the most challenging? Yeah, so the same size nodule on different locations. The volume we can ablate is different. So for me, the number 4, right, is the most challenging. It's next to the in front of the trachea and then under the strap muscle. It's very kind of superficial, the large, expansile. Yes, it's very challenging. Number 3 is really also next. It's challenging because it's close to the phalangeal nerve in the right lobe, and then also I should evaluate the posterior lateral. It could be challenging. The easiest one is definitely, I think, is number 1. So yeah, as you see here, the position location of the nodules affect our procedure. So vascularity-wise, Dr. Pang and Dr. D'Andrea already mentioned about that. So I'd like to skip that. The vascularity effect in our procedure, especially when there's a many vascularity around the nodule, nodular space, because of heat sink impact, some components are untreated and then will cause some regrowth. But intranodular, I think I agree. It's more, kind of enhance the whole ablation. We have a more better effect with the ablation. All right. So then this is a paper who adapted Dr. Beck's idea about artery first, modular venous ablation, and then they show that some meaningful more volume reduction with the artery first technique. So moving shot technique is really a key to have more effective ablation in a short period of time. But one thing I try to understand, if we enter a single entry point of the nodule, definitely will leave a blind zone. To compensate this, then I should go to the opposite direction. I should have painting shape. I should have covered the blind zone, but we don't practice like that. Then let's say that we have sphere. Wherever we go, we can easily control this half of the sphere. But proximal hemisphere, because of entry point, we are limited. We are leaving a blind zone. We are almost like a cone shape, volume, like an ablation reduction. So I calculate that from the sphere minus hemisphere, then again the remaining hemisphere minus this cone, then what's the remaining volume? That is the blind zone. I realize it's 25%. I think pretty much it's a match with the non-ablated zone, or during the follow we leave the 20 or 30% non-ablation. So operating technique is really important. So more proximally, more ablation zone overlap, but the distally, the ablation zone are not overlap. If they are not overlap, we'll leave some untreated area. But because of heat transmission, I think more wider areas are covered and treated. All right. So Dr. D'Andrea, he nicely explained about the dependent modality, energy delivery. We have different reserve. So I saw review pretty much the factors which can affect our procedure. So if you understand these multiple factors, the nodular or operator factor, and then we should try to improve personally our skill, have the right tool, and then really well understand the characteristics of the treating nodule. So I think really important thing is we should have very diligent follow to see that our treatment is going to meet all this kind of milestone, more than 50% at 6 months, and then 10 to 20% more over another 6 months, and then gradually year after, till 5 years, if you have a more volume reduction, our recurrence regrowth rate really low. But anytime you find out that there's a need for reintervention, I think we should do something. So I think very careful long-term follow-up seems to be very important for us, even you finish with a single session. Thank you.